section of the Behavioral Division of the UCLA AIDS Institute that I'm speaking to you today. And it's my pleasure to welcome Dr. Airhihenbuwa to the UCLA AIDS Institute. Airhihenbuwa is professor and head of the Department of Biobehavioral Health at the Pennsylvania State University and director of the Pan-University Network for Global Health. He is a global expert on health behavior with a track record on the central role of culture in health behaviors. He's led numerous research collaborations, institutional partnerships, and mentoring of faculty and professional staff at various institutions globally, and I'm proud to be one of his mentors. Mentees. As the author of Penn 3 model, his work has informed ways of addressing the intersection of culture, identity, and health globally. He is a consultant to several UN agencies, including the World Health Organization, UNAIDS, UNESCO, UNICEF, and UNFPA. He has led one of the earlier World Health Organization efforts to galvanize multidisciplinary efforts to address HIV and AIDS in Africa. He's the lead author of the Communications Framework for HIV and AIDS, the UNAIDS Communication Framework for HIV/AIDS, a new direction, published in 2000, sponsored by the Joint UN Program on HIV and AIDS. And this involves 103 researchers and practitioners from 5 continents, with the final report translated into French, Spanish, and Kiswahili. He's authored over 120 articles, book chapters, and books. Books include Health and Culture, Beyond the Western Paradigm, and Healing Our Differences, the Crisis of Global Health and the Politics of Identity, and Ethnicity, Theories, International Perspectives, and Challenges, with the co-editor Agiman and de Graaf. He chairs the advisory board of the Global Philanthropy Alliance, which funds projects in South Africa, Kenya, and Nigeria, and he's been a member of the board of scientific counselors of CDC, a former president and distinguished fellow of the Society for Public Health Education, a fellow of the American Academy of Health Behavior, and the Academy of Behavioral Medicine Research. Beginning in January, he will assume a new position as Dean of the College for Public Health and Social Justice at St. Louis University in St. Louis, Missouri. So, thank you.
Am I able to move around, or should I?
Yes, you are.
I can. Thank you so much, Chandra. And it wasn't a slip of tongue for her to say, my mentor. There's actually an expression in my language that your child becoming greater than you is a blessing. So the height of being a teacher is when those that you taught become your teacher. And some of that I'll talk about tomorrow in leadership and the role that she played in advancing critical race theory to public health. But for today, we'll talk and have a conversation around culture and health. Thank you for the invitation. It's always a pleasure to be here. And I think the first time I was here too, Chandra invited me and Kamara Jones to help think through some of the issues around critical race theory applied to public health. This was 4 or 5 years ago? 2009, or maybe a little, yeah. And Kamara is the president of American Public Health Association, and Ending Racism as a Public Health Agenda is her platform, which she announced last week when she took on the presidency. So clearly, the work that Chandra and a number of you are doing here is having an impact in a way that one may not have, or you may not even imagine or appreciate. It's good to be here, and what I like is, I call it a polylogue in terms of conversation occurring simultaneously rather than a dialogue that is only bidirectional. So if you have any question you want to ask, it's okay to ask as I'm going through this. My conversation, I always call it journey, and I'm trying to hide behind the light here, so I'll stay here. It's a journey, and most of the things that I do, I like to put it in 3 components. in part because when I was growing up, the three-legged part of the cooking pot has something very symbolic for me. So in fact, I ran 2 circles of strategic planning for my department. Each circle always had 3 priorities that we undertake. So my journey will be in 3 parts. I always begin by letting audience know that I'm interested in questioning the question. I'm not one to provide solution. And because I believe that questions are framed in ways that the answer is a given. And so we always have to learn to question the question. And through that, we begin to look at why inequity in health and what are we learning. And then we'll talk briefly about HIV/AIDS and culture, in part because when I talk about HIV, I really don't talk about HIV. I talk about what HIV has revealed. And that is inequity in our system that we had to confront because at the height of it, there was not even treatment. And when you have a condition for which there is no treatment, and for which there was even no therapeutic intervention at the time, you had to begin to confront what creates vulnerability and how do we end up in such a place where location begin to become the issue that matter most when we address issue of vulnerability. And we saw that most recently with Ebola, which is a different lecture entirely. But what creates vulnerability? So in questioning the question, it also occurred to me that we have a number of assumptions we make about conditions that people face. Some of the assumptions that we make that we never really quite question or interrogate. And so I want to begin by raising question about how issue of vulnerability link with identity and location create an image in which people may be victimized when in fact they, in terms of the way a particular condition is framed. And Chimamanda Adichie her latest book is Americana, which received worldwide acclaim. I understand that Brad Pitt bought the right to it and it will be made into a movie at some point. But this is a TED Talk that she did some years back, and if you have about 22 minutes, I strongly encourage you to watch it. The idea of a single story is the way in which we try to simplify complex issues into one story, whether it's about identity, about who we are. There is this danger of a single story we create about who are the blacks, who are the Latino, and who are the Asian. And we're talking this morning about how the writing tend to universalize Asian as one group. And we don't even, for the most part, talk about Native American. We sort of totally ignore, pretend that they don't exist. So the danger of a single story, for me, can be illustrated in the story of Tuskegee. If you ask people what do you know about Tuskegee, they tell you about the syphilis study, but they don't know that a lot of the things that you do in public health, in community, actually came out of Tuskegee. They don't know that taking your clinicians to the population or even creating mobile units were things that were pioneered at Tuskegee, where practices that we engage in, that we celebrate. We have National Public Health Week. It's all ideas that has been pioneered in Tuskegee. Yet, when people hear about Tuskegee, they hear one single story. They don't hear all the positive things that has occurred in Tuskegee that actually form the foundation on which we base our current public health identity. The same is true about the way we think about location. there are these geographic or cartographic representation that sort of align our sensibility, our visual sensibility to look at a particular location from one particular lens. My hero, as the late Chinua Achebe, among so many things that he left off with was this notion that no one should enter their home through somebody else's gate. And it is actually, for me, a lot more profound than the structure of what one imagines when you hear entering one's house through somebody else's gate. And as you will see later, it applies to theories and model. It applies to academic discipline. It applies to the tension that one sees between public health and medicine and other clinical encounter. The question of through whose gate do we address the issue that we all share in common, the things we all feel most passionate about. But for, in terms of cartographic representation, if you enter my office, this is what you see. The question of why is the north, and why is the south, who drew the map to position what we've come to normalize as our way of knowing a particular location. People from different parts redone the world map. Canadian, Australian redid the world map, placed Australia in the top so that they are not down under. So a part of what I want to leave you with is that questioning the question is not just about health. It's starting with our assumptions about knowing. The knowledge production processes that actually has create or sort of naturalize a particular way of thinking about a people, a geographic space, and the relationship we have with that space. So we sort of have to turn that upside down or disturb the comfort that we feel when we hear about these places or when we imagine these places. Because theory and practice are cultural. Every theory, every practice has a cultural anchor. Because it doesn't pronounce it, doesn't mean it doesn't exist. You begin to understand it when you start to look at the limitation of what we know in terms of how the efforts that and resources that have been invested into intervention that are supposed to work are not translated into needles moving the population health. So some of the best and most funded and most resource research entity are also located in some of the places where you have the highest disparity in terms of institution to population. The excellence in research based on the metrics we know for measuring success has not translated into changes on the ground. Whether it's on HIV and AIDS, whether it's on smoking, we are now going to be dealing with, we're already dealing with obesity research. So the question is, are these metrics based simply on health and medicine? Are they based on culture? Do we consider race? Do we consider gender? And in doing so, what are we really studying? Are we studying people? Are we studying behavior? Or are we studying diseases? We tend to focus on disease in terms of looking at outcome. And then when we address issues of social determinants of health, we are looking at people and structure. How do we make the connection where resources continue to be invested in disease outcome, but what we know and number of scholars have been telling us is actually in people in their relationship and expectation, in what I call socio-cultural infrastructure, because it occurred to me that the places that were the least resource in Africa, like Senegal, that maintain a very low HIV rate, we have not looked at the infrastructure socioculturally that allow them to maintain that low rate. And then when you look at places like Botswana or South Africa, that more highly resourced country are the one that has the highest HIV rate. But if actually you look at South Africa, it is the areas that has the most highest form of physical infrastructure that also has high HIV. So we have not looked at the relationship between cultural infrastructure because we haven't framed it. The question is being around infrastructure that with other metrics that do not really apply to what we consider success. Then the question becomes when you are looking at the population, why are you interested in a particular population? As I ask when I talk about in the African context, do you become interested because you saw one of these programs on television that shows a child with fly on their face? And then you suddenly decided, oh, I need to go help those people. Is it about helping? What happens when you are interested in a population because you want to learn from them? As was the case where, and I mentioned this morning, for years, entertainment education has been proven to be very effective in other countries until a scholar in the US said, wait a minute, some of the people that made it so popular in other countries are American. Everett Rogers was one of the champions of them. Why is it that it's not being looked at in the US until started seeking funding to look at what is entertainment education, how does it benefit? So learning from other places where you are drawing example from what is work. Or what about issue of social justice? That creates a different space for engaging a population. So why you are interested in working with the people is going to influence the type of assumptions that you subscribe to in terms of models and theory, and how well the project is going to actually have meaning and be sustainable within the population. And for me, when I was asked to address the World Health Assembly some 3 years ago on what lesson have we learned from HIV and AIDS and how does it apply to non-communicable disease, which is actually outstripping infectious disease burden in African countries. My question was, we are so wedded to a low life expectancy at birth that is sort of skewed the way we think about burden. That if you take 3 countries, the US, Nigeria, and Ghana, and you look at life expectancy at birth, age 5, age 50, you have different story. So if we are really serious about non-communicable disease, so life expectancy at birth, which is a language of high infant mortality rate, does not tell us the burden of disease within this country. Nigeria alone has over 13 million people who are 50 and over, which is double the population of Switzerland where we're having this conversation. So questioning the question is not to reject what is there, it's to question whether or not what we've been wedded to as the convention for metrics for measuring success still apply when we are having new forms of challenges, as in the double burden of both infectious and non-communicable diseases. So how does that relate to some of the issues of today? If David Williams has already been here, as I understand, you probably would have seen this. Because I think it's very important in the global context to start from home. We have, with the richest country and still the most powerful country, even though for the first time, a US president wasn't ranked on top of the most powerful people. And you wonder why, first time a black person is the president and it's not ranked. So that's a different debate and different conversation entirely. But it's still the most powerful country. But when these are it's information that I would imagine David would have shared if he were here, that in 1980 life expectancy, assuming, let's stick with it, that these metrics that we still apply, US was 11th, by 2006 it's become the 33rd, tied with Slovenia, and ranked behind Cyprus and some of these other countries. And for those who say it's because of the minority population, the question was if the US were only white, it would still be ranked 30th. And so one should not make assumption as to what role minority play, and if it was only black, it would rank 58. So these are ways of really to begin to understand why issue of disparity and social determinant of health is central to how we understand HIV/AIDS and other disease outcome. Because it is not disease that I'm most interested in, it's the people and the location that I'm interested in. He may have also shown this, that when after the 2008 report from the World Health Organization, Closing the Gap in a Generation, some of the lessons that we learned was that in doing comparative analysis, it's one thing to compare US to Canada or US to Nigeria and other countries, but it's even more important to consider comparison within a particular location. One could be between Montgomery County in Maryland, which is one of the richest counties, and Washington, D.C. in one direction, or Baltimore in another direction. And the difference in life expectancy was close to 30 years. But we can even get beyond that and say, let's just look at city, which Robert Wood Johnson Foundation has been supporting in this project, that in DC alone, depending on where you are on the metro line, the difference in years could be 7. If you are in New Orleans, it could be up to 25 years. So you have to understand the importance of why place matter in what we study, and not simply how one country compare, but that when we're talking about social determinants, structural determinants, it's what creates this huge gap within a space that one can get to within, in some cases, 15 minutes, but having this huge gap in years. Structure matter, we've known that for many years because in the Philadelphia Negro study, W.B. Du Bois cautioned about using relative statistics in terms of how one compared to another and looking at the totality of the experience of people who have populated a particular geographic space. That it is not enough to simply see how blacks compare to white. What is more important is to understand the totality of the condition in which and in the environment in which blacks live. Frantz Fanon is also cautioned about this globally, that it is very important to understand the psychology of the oppressor, something that I'm blanking out on, Toni Morrison subsequently echoed in a small book called Playing in the Dark, that the psychology of the oppressed is important to understand. What is even more important is the psychology of the oppressor. What creates a space, an environment, or a system that where individuals engage in practices that subordinate others. And that these are really very important to examine. And of course, Mary McLeod Bethune that says the true worth of a race must be measured by the character of its womanhood in terms of the location of gender, in how we look at this location and places as we begin to look at disparity and inequity. Audre Lorde cautioning us that to come up with a new thing of model is important, but be careful not to dismantle the master's house with a master's tool, that the tool will not produce a new idea. If you want to come up with a new concept, you have to start with the tool, not looking at the structure using existing tool. It speaks to the assumption around theory and model, and that is something that we want to talk a little bit more about. Paulo Freire, whose work actually gave a lot of attention to the notion of raising critical consciousness, even though it was translated into language of empowerment in the academy. He actually said he never used the word empowerment. That is how his word was translated. He talks about raising critical consciousness. So when he was asked about this, he basically said, to follow me, it is necessary not to follow me. So the idea is that you take my concept, you have to start from beginning each time you are engaging this concept. So these are ways of raising questions about the notion of change or improvement or excellence that is really encoded in a conventional way of thinking that has not translated to changes in population health. And that comes the issue of race, racism, and culture. Well, we know that, I'm probably going to need water at some point. Sorry. We know that Derek Bell and just the genius of a man in terms of I can go into some of the history of how he started wrestling with the issue of how race define what we do, how it's systematic, it's structural, and going back to the document of Serving Two Masters and trying to understand how community was responding to separate and unequal law that was being challenged, and what it means when he, on the one hand, working with the Legal Defense Fund, on the other hand, having children, family who are saying, when we go to an integrated school, our children do worse than they did when it was a segregated school. So he has to start wrestling with, what is it when policy has good intention, the outcome is negative for the community, how do you reconcile the two? And it led to the creation of critical race theory. And thank you. And of course, you know about how this has translated into policy. And you would have remembered the Beer Summit. What is interesting, I don't know that Brother Gates took the issue as seriously as he had to confront after this encounter. Because there's a sense that what he experienced was something that was common in a different class, not somebody at his level, until he had to deal with some of the things our brothers and sisters in the community deal with on a daily basis. It was a realization that you and I in academic environment are not immune to those microaggression injustices, outright racism, no matter what time we call it, that had to involve the president of the country. But this is why it's so important, as I said, with Kamara Jones becoming the president of American Public Health Association, and basically saying my platform is going to address how you end racism in this country as a public health measure. Well, we know that the mechanism for doing that is already been put in place. So we are going to, we can talk about that, and I think the conversation we had this morning is a testament to what has been going on and the role that you play when I talk tomorrow about leadership, why it's so important to begin to think leadership at the point of training. And capacity building is as much about leadership as it is developing skill. And it takes leadership to advance new ideas and to maintain the tenacity to continue addressing those issues, even in the face of doubt as to whether or not one can succeed. But it's how you negotiate that and how you navigate the system is part of what the conversation this morning with the group was about. It's part of why it's so important. In lectures I've given in the past 2 or 3 years, most of it has been because I just felt that there is a part to what we need to be doing that relate to this work that occupy the space of leadership that we don't talk about. We need to talk about it more. But going back to how we address issue of inequity and the role of race and identity, we just went through 30 years of Black and minority health. And when HECLA report came out and looking at excess death in the country, and 30 years later, the number has increased. In fact, the way you language a problem always influence the response and the intervention that follow. Death is a clinical issue because of the way system is structured. So if you want to prevent that, you go to a hospital, so all the resources went into the hospital. This expanse of space that occur before death occur, we totally ignore. The vulnerability that occurs in the space that public health and population health occupy did not really feature in the report, even though individuals who were involved were not all clinicians. The focus was, we have excess death, we need to go do something about it. And years later, we start to wonder, why is it that nothing is changing? If anything, as Sasha will say later, the number has gone up. What have we been doing? Because the focus has been in the way the problem was defined and framed, and which is why the framing and the language of an issue is so critical in terms of how we address the issue. Well, we have the Affordable Care Act. It's now passed into law, and it's quite interesting when you go back to history of how we came to this, and this is really not the ultimate form of protection, but it's giving us something to work with. But in all of this is be the debate between the self and the collective, the individual and the group. Who takes what responsibility? What is the responsibility of the state to protect the population? And what does that mean in terms of balancing the responsibility of rights of what is considered entitlement, what is considered a right? And that has been at the core of the issue of how U.S. differ from France, differ from England, Canada, and some other country. And it is nothing suggests superiority of the French for having fewer problems with obesity than the U.S. It saw a cultural system frame within the system. It's how we choose to address the balance of self and the collective. There is nothing superior about British having about 10% C-section to U.S. having about 25% C-section. It's how we frame the system and how we codify what is important and what we are prepared to invest in. And the debate between the self and the collective takes a different form when you are looking at how the U.S. hyphenated Americans, I should put it, are addressing issue of injustices. Because for the group, it's a question of the collective. For the system that we are dealing with, it's a question of the individual. And you heard the comment about you don't have a boot, somebody is asking you to pull yourself up by the bootstrap, and that would get you the boot first. But the question of issue of the collective is beginning to takes a different from, it calls us to rethink what do we prioritize. Again, the Heckler report talked about excess death. When social determinants of health started to gain momentum, the World Health Organization assembled a group of people to come up with how we look at this at a global level. And Sasha represented the US, and he came up with a 3 basic recommendations: improve living condition, address issue of imbalance in power, gender imbalance of power. And when you've done those 2, come up with a different way to measure whether or not we are achieving what we are achieving. And that is what gave room to this different way of thinking about inequity, of not simply comparing one country to another, but looking at intra-regional, intra-city disparity and inequities. Today, Robert Wood Johnson Foundation is actually rating institutions and rating cities on some metrics that has been identified and considered to be important for the collectives to work on. Since the 2008 report, this came out this year, and there was a whole big splash in New York. There was a huge concert, the 17th priority of the United Nations, because the Millennium Development Goals that had 8 goals, there was a sense that not some things were accomplished, but not all the things that we hope will be accomplished. 2 areas, maternal and child health, was one of the areas that did not gain the increase in health outcome based on intervention, investment in resources. But if you look at all of this, it represents what all of you and many people here believe in: no poverty, no hunger, good health, quality education, gender equality, clean air and sanitation, clean energy, good jobs and economic growth, innovation and infrastructure, reward, reducing inequalities, sustainable cities and communities, responsible consumption, protect the planet, live life below water. We have to worry about life above water also. Life on land, peace, justice, and partnership for the health goals. And these are still dealing with, I shouldn't say still, these are attempts to deal with not necessarily disease outcome, but the issues that create vulnerability in population. It's really what it boils down to. That if we are to deal with inequity, we have to deal with issues that create vulnerability. And that education is very central to that. And what does this mean? Well, it means how you're going to attack multiple strategy. You heard of Yogi Berra that's made all sort of goofy statements. And one of these was that when you get to a fork in the road, take it. But that's actually what we have to do. It sounds impossible, but it's actually possible when you think about it. I don't know that he intended it that way, but why is that? Because in the past 2 years, actually last year, I had launched a new network at Penn State called the Pan University Network for Global Health. And our goal was to focus on two priorities. One was urbanization, the role of urbanization. In 2020, the rural area will stop to grow, and there's going to be new ways of thinking about urban living that is different from the way we understand it now. Different from, you go to different countries, because of migration and the stress put on resources are available, urban areas are going to take on new shape and new challenges, and that is one priority. The second priority has to do with this. We say infectious and chronic disease. You call a meeting to address global issue or health issue. So infectious disease expert will say, well, you're dealing with chronic condition. We really are not a part of that. You kept us out. You call a meeting of the chronic disease, infectious disease group, chronic disease, and say, well, we really deal with chronic disease. We don't deal with this infectious disease. The question is that some of the conditions we have are neither one or the other. They are both. HIV is both infectious and chronic. So is TB. So is some form of cancer. So we have to debunk the false dichotomy under which we operate and begin to look at how do you come up with a priority that obligates everyone to be at the table to collectively address issues that is facing the population, the global south in particular, that live with coexistence of infectious and chronic conditions. There are actually treatment form for HIV that leads to higher adiposity that we are seeing in South Africa, leading to not just diabetes or obesity, and this was documented in Limpopo in some of the work going on in South Africa. So we cannot think in terms of one or the other. Infectious, or we need to combine both. So the second priority for that network was to look at the intersection of infectious and not communicable diseases, so that we look at, with thinking in terms of a new language of vulnerability, moving beyond multiple mobility to multiple vulnerability, where different conditions coexist. The same population or family that has someone that has malaria, has HIV, TB, hypertension, and diabetes. So if you were doing a work or intervention that is based on family system, you can't simply focus on one disease or focus on the other disease outcome. You have to look at the totality of what a family has to contend with, what the challenges they have to deal with. Then you have to go to the system. Are the health system really equipped to deal with this condition? There are some of these conditions that receive such global attention that vertical programming provide resources for one. So it is quite typical for someone who has HIV and also has diabetes, go to the same hospital, go to one unit for HIV, and has to go back to a different unit for their hypertension and diabetes treatment. In the meantime, the clinicians are not communicating. There's no way of knowing. And so the system, we have to rethink, what does this mean to have multiple vulnerability? What does it mean for our system? And what does it mean for social and structural determinants of health? Generation public health, which is what you heard a lot at the American Public Health, that this has to be generation public health. Or the culture of health movement that Robert Wood Johnson Foundation is championing. How does this all converge into a social justice as a priority for public health, where it is not the disease, it is the population and location that is going to be our central priority. So how it relates to health and culture, Wole Soyinka, a Nigerian famous, considered conscience of the country. Man is first a cultural being, which is why he resorts to his cultural affiliation when politics appear to have failed him, never the other way around. Everything for me is culture. The system, structure, everything is cultural. Culture is not simply about how you eat and wake up. It's the system that organizes your thinking. It's also not something about, it's not about what is negative. It's also what is positive, and I'll speak to that in a brief moment. But it really comes down to this for me. It's a Native American expression that said the longest journey you ever take is the journey between your head and your heart. So the challenge academics have is that the heart is in what needs to happen in the community. The head is in what agencies are funding. And in a lot of times, they are not aligned. The head wants to go where what is rewarded. The matrix for success is measuring everything that the head speaks to. The heart says connect with the people in the community and do social justice. It is not connecting. And that really is where the challenge is. And some of the ideas that we've advanced, whether it's on culture or addressing racism, is actually making that connection between the head and the heart. And I try to illustrate that by looking at African way of knowing and using some aspects of the Pen3 cultural model. In this expression that says, until the lion produced their own historian, the story of the hunt will glorify always the hunter. And that is why you have the meeting this morning, and that is why we get a group of people to talk to us. That is why we advance a different way, a new way of thinking about the issues that are there, that we need new historians that are going to tell the story of inequity, that we actually move beyond disparity as a quantitative language and measure and talk about inequity, which is value-based, because the inequity is really the unfairness that exists even when something is unequal. School of nursing may be dominated by women. We don't say it has to be men and women because it is not inequity. It may be unequal. It's not inequity. It's a question of always the value system and where the fairness occur, and that is what we are looking at is inequity. So it goes beyond inequality. So we need new historians, new scholars, new thinkers to be able to advance this out, to move beyond the conventional way of looking at differences and unfairness. And in terms of relationship and expectation, no one should enter their home through somebody else's gate. The first one is about capacity building. When we talk about the historians, this is about the mechanism, the theory and models that are developed. And it's why we have critical race theory applied to public and why we have Pen3 model. To give you a different way of constructing a new gate through which you enter the community. Because a lot of the time, we say no one should enter their home through somebody else's gate. You see your gate, you don't even recognize it because you are so accustomed to valuing other gates. You even think you don't have a gate. There is no way of entering my community. My community has no gate. There has no way of entering it. So there are gates. That is what that second area is supposed to have you think about. The last one is cultural identity. Do you know who you are without what you do? See, academics are notorious for walking around. I'm professor of this, I'm director of this, I'm head of this. And then you go to a community, you are trying to engage them at the level they are functioning. But you can't seem to get away from the title of your academic affiliation. So if you do not know who you are, how do you intend to engage the community at the level they are? So a part of know who you are without what you do is, so if you do not know who you are without what you do, then you are basically saying that you are totally useless after you retire. Because it's a position, a space you occupy that is not supposed to be in perpetuity. So when you no longer occupy in that space, that person that you are supposed to be is really who you are, and that is the level you have to engage the community. And this is how why we developed the Pen3 cultural model. And I'm not going to go into detail of how we apply it, but the important thing is that this category is really very common to a number of the conventional theory of model which we train students, whether it's head belief model, reason, action, even principle-process framework. A number of the conventional, we always deal with what is the view of the individual, what are the resources, and how do significant others support you. And that is what that represents. But a part of what I wanted to make sure is that in every community, what I say is that if you go into a community to do a project, begin with something positive. If you cannot find something positive, then you get out or you become a part of the problem. Because every community, every idea, every institution, we can complain about our institutions, there are positive things there. And we can complain about a group we belong to, there are positive things there. We are so accustomed to training people to think about negative that we have no way of even understanding or appreciating what is positive. It is not accident that mindfulness is gaining so much attention, but because the idea of celebrating something positive is very important. Start with something positive. And then you look at those unique values before you get to negative. And in negative, it's not just about what individuals are doing, it's how the structures are conditioned to create the outcome and expectation that we observe in individual behavior. And this is what we do. We create 9 cells and begin to look at what is important and what, when we collect information from the population, we group it into the 9 cells. We go back to a community and say, we don't show our grouping. We say, when we came into the community to get this information, here are a list of some of the things that we were told. Could you help us tell us which of this group you would consider to be good? Which of this would you consider to be neutral? Which of this you consider to be negative? After the community is done its grouping, then you show what you've done so that you can have a conversation as to why we had differences of opinion in certain area, some of the things that we agree on. That is the beginning of ownership over how we are going to frame the strategy for the solution. Because the solution, sorry about the color that is person, extended family, and neighborhood. The solution is a collective effort. The strategy and what journey we have to engage in to address what has been identified. It's a collective effort, and that is where the cultural identity domain is. So we always have an assessment phase where you go into the community and you collect information and you have tables created. Then you have intervention phase where you are reporting back and you are prioritizing what needs to be done. The planning and actually deciding what exactly is going to be rolled out and how will it be sustained. And in doing so, in the work that we did in South Africa on stigma, HIV stigma project for about 5 years, we wanted to understand what is stigma to start with. We understand it from the concept of how of engulfment defining in the 60s. We understand it in ways that Michel Foucault talked about the location of power, but didn't really talk about stigma, but this is the same issue that he was addressing. But when it comes to addressing issue of belonging, acceptance and belonging, that's really what it comes down to, because when we did the study, we didn't put stigma in any of the questions we asked. If it's raised, it has to be used by somebody in the community, not by the researcher, because we didn't want to influence the direction of the conversation. But it's acceptance and belonging. When it comes to that, it takes different form. And questions that came out, just 3 that I wanted to briefly share with you, is that food was at the time used as a way of measuring stigma, that if people don't share utensils, then you know there is stigma. Somebody is not knife and fork. And the question for us was, well, what happens in cultures that do not use knife and fork to eat? What would you do in my culture when we eat with finger? So you have to think of a different metric. So that doesn't really help us with look at. It doesn't mean it's wrong in this context. It simply means that it's not universal, it's not global. And then the question of disclosure was, we talked to a group of elders who came to us and said, look, in our culture, if my niece is sick, my niece may not go to her parents. They come to me as the uncle, and I call a family meeting. Now, we have a policy in South Africa that you cannot disclose someone without their consent. So I want to know what is my responsibility now as an uncle who is supposed to make this decision, and the policy said I can't. So this is where you have 2 good intention conflict to produce a tension that has to be negotiated. Because on the cultural part, what the uncle was saying was quite accurate. That was a way of providing a safeguard where a child does not have to, if a child is really afraid of how a parent might respond, you always have someone in the family you talk to. But if the family is under a gag rule because of the policy that was it was a good policy intended to ensure that people are not being discriminated against. We have to talk about this tension that result because in both sides, these were good things that were meant to happen. The question of motherhood, the mother that takes care of everybody, then what happens when she is sick? Who takes care of her? And these were, and then even beyond that, we started to zero in on the nurses because a lot of study came out and said nurses stigmatize against people living with HIV/AIDS. They come into the clinic, they read out their names, and then before you know it, words go out into the community. So we started talking to nurses, and nurses, what we found out was nurses were basically saying, when we are at the clinic, people only see us from that particular agency, but we're also mothers, wives, sisters, aunts, people in the community. We need help working with us, as someone working with us, to address how you deal with a condition where you see people dying and still be able to go home and be intimate with your husband. And that we don't have a process of working with that. Or once you're done with your work, a member of the community knows you are a nurse, calls you to seek your advice about what is going on in the community. So a part of the project that grew out of that motherhood was that there are multiple agencies in nursing that we're not looking at. All we are interested in what she did in the waiting room. After that, we never followed up to see what is really happening to her. What is happening to her when she's having problem being intimate with her husband because of what she's experiencing. So again, the danger of a single story where she is framed from one particular experience based on study that has been shown, but no, we were not looking at the other spaces that she occupied. And I used this in the work we did, and the result that talked about food that you eat with your finger. Your left is injera in Ethiopia. The right is chebujen in Senegal. That little one is 17 years old now. That is my son. Again, questioning the reliance on utensil sharing as a way of measuring stigma in culture that do not use utensils. So beyond that, we looked at how the PEN3 model is being used over time. Former students actually did the work on this. And some of the things that we found, I'm going to, or maybe I missed, I think I skipped. Some of the things that we found I can tell you. There was one, there's an area of use of PEN3 that is looked at, the contradiction between the message of intervention and the ways of being, ways of knowing and growing up in a society. You are a black male or you are a male, but this time I'm focusing on black male. You're a black male, you are taught to be stoic, don't share your emotion, don't be crying that day. In fact, if you cry, they call you, are you a girl? And then now we say, go to the clinic and get tested for something. Go and get preventive care. You need to go to the clinic and see if you are sick or if you have a problem. But the idea of being a man that you were told is that you don't ask questions because you don't have, even when you have problems, you shouldn't even cry. That there's a contradiction between the message of showing vulnerability and being raised to not show vulnerability. And number of scholars were raising this in the work they were doing using the PEN3 model. There is also an issue about, I already talked about the role of nurses. The second one was in terms that tend to assume this singular interpretation. Machismo is an example in the work of Deborah Irwin, that when she did this work on cervical cancer prevention among Latinas, the question came up that why is machismo become a negative term? We like machismo. When a man is doing what he's supposed to do for the family, that is positive machismo. When she is being a man, as long as she's not doing something negative, that is a good existential machismo. It's when he's not doing what he's supposed to be doing for the family, that is when we look at the negative. That the literature only focuses on the negative part. We actually also like it when there is a positive part to it. So spread it And in fact, we don't want you to do this intervention with just us alone. We want our husband and our spouses to be a part of it. So they have to revise their intervention and make it a family-based intervention and not simply focusing on women in terms of assessing prevention of early screening for cervical cancer. So the third part is I will talk about tomorrow, the role of leadership in capacity building. There is a sense that we need more capacity building in what we do, and that we needed to have more people assume leadership position. Begin with the positive, work with the community, be comfortable with being uncomfortable. And I think this person said it well, if you talk to a man in language he understands, that goes to his head. If you speak to him if you talk to him in his language, I hope I've been talking to you in your language, not just what you understand. That goes to his heart. And that is Mandela. And in terms of understanding how you address issues of social justice, to understand a language is the first step. What you want to do in working with the community is to speak to them in their own language. And I throw this as a last example here because this is Soweto. The story of Soweto is typically this. And this is also Soweto. People who may not have material resources got together and create this community garden. This is also Soweto. These are $1 million homes area in Soweto. But the single stories tend to be one of these. And you find this in every community, that a question of what is the intention. You have a whole community, and the only perspective you have is one. There's a second perspective, and this is deep. But the story of Soweto is really people who live there. This is a young man, fascinating story of somebody who started a tour with getting people to walk around and not stay in a vehicle looking out the window as though people they are afraid of the people. It gets you to go around and shake hands and meet with people. A different way of thinking of going beyond one story. In research, relationship and power balance, in method, culture, structure, race, and all the things that we begin to learn more and more about. In intervention, you must be positive and you must think about the family. Thank you.